Well, I want to first just start by saying how motivated I am at 3 o'clock and at 2 o'clock in the afternoon, and I know it may be different depending on where you are, um, to just hear about the importance that we have brought to every type of project or initiative that can do the proverbial moving of the needle. And that is that when you have good science and clinicians who care, when you have community engagement and leadership that is prioritized, and when you have folks in policy that can really help to us to understand what it takes to advance action, we can collectively make a difference. So I've been super motivated, and certainly in my work at Morehouse School of Medicine and connected to this over the past year, I'm very, very excited about what we will do together, following all that we've heard during the past day or so. So hopefully you all can see my screen. So someone give me an okay. Can you see it? Wonderful. So I want to start by saying that a lot of what you all described, everyone on yesterday and today's panel, and particularly, I'm really pleased that the time that our community partners have taken to join us over the past 2 days to hear and really help us advance our collective efforts, because we have health disparity community leaders who are not just necessarily affected by adverse health outcomes, but they are leading in ways that none of us can. They are the voices that are critical to the understanding as well as the movement that's critical to this effort. So I want to thank them for being on, all of them that made time to be a part of that. And I want to say that it is in part because we at Morehouse School of Medicine have tried to continue to be eligible of the community's trust. So when we think about research, when we think about other initiatives, frequently as academics, we are looking at community residents to find out if they're eligible based on certain criteria to be a part of a study. And so for us, our intent, and I'm sure based on what I've heard, that of all of us, is to flip that script such that communities hold us accountable to ensuring that we maintain our eligibility of their trust. And so that is why, again, I thank those who've been with us for all types of initiatives to share their voice and certainly to hear what we've talked about now and help us to take it to the next level, which a lot of you just described. So I'm in the Department of Community Health and Preventive Medicine here at Morehouse School of Medicine, and I'm also Associate Dean for Community Engagement. And that just means making sure that the left hand knows what the right hand is doing, whether it's clinical, research, training, et cetera. And that, more importantly, community residents like Mr. Ward, Mr. Fletcher, and our community doc, who hopefully is still on the line, that they not only advise us, but they govern and help to ensure that community voice is always central in all that we are doing. So I'm going to give you just a brief overview of what we've been working on. And some of it really, again, is exciting because it speaks to the power of our and the potential for our partnership and some of what we already have underway. So for the past year, we have been working on conducting a systematic review. And hopefully you've seen my slide change. But the intent of that review is to amass all of the research and evaluation literature from 1996 to present, and that is the peer-reviewed literature right now on studies that have engaged older adults with a special emphasis on health disparity populations. So we think of that very broadly. And so we know that they're characterized, as much as many of you have already described, by race and ethnicity, but they also include socioeconomic status, sexual and gender minorities, and also what we know now are distinctions in access, understanding, and engagement depending on where people are, particularly the distinctions between rural and urban populations. And so this past 18 months, which we are still in, has been focused on a scour of the literature to understand what exists, but also what the gaps are in the research and the clinical outcomes related to engaging older adults in cannabis research, clinical studies, and also in this really understanding where in these studies is there a deep dive into their perceptions, attitudes, knowledge, and some of you talked about education surrounding medical cannabis, their use of it, etc. And a few of you also talked about the distinctions among Latinx and Black communities and how they perceive that across the life course, but particularly among older adults. So that information will be used in part to inform our next phase, which will start in March and April. And let me first start by saying that, how we engage with you to find out what other central repositories of evidence exist, I think is really important. So I appreciate what you shared, Dr. Chanda, about the collaborations across HBCUs as well as other agencies and policy advocates to amass the current body of evidence in a place where we all can access it, but also such that others across the country and the globe see us as the leader in where that information, where that repository exists. So in March or April, we will do what I know Dr. Ward is very familiar with, and that is that we have been very thoughtful in engaging thought leaders in the community and community conversations by way of focus groups. And the most recent, just as a point of comparison that we had this past year, included engaging health disparity populations like those that you can see on the screen in discussions about how they want to be engaged in research. The intent is to gather their perspectives and recommendations so that researchers and clinicians can do it better. And so I think that broader universe of discussion, which Mr. Ward has been very involved in, is, I think, a great framing for how we will approach this type of conversation surrounding medical cannabis perceptions, attitudes, and whether people use it and why. And we cannot ignore the realities of how COVID has really layered people's perception of anything related to the medical or academic or clinical establishment. We certainly have to acknowledge new perceptions of research, but also continue to acknowledge the historical inhumane treatment of certain groups, and particularly older adults who either were there when things like Tuskegee, Henrietta Lacks, and other atrocities happened, or know that it was something negative and they don't want to see it happen again. So we must acknowledge where we are as a nation and as a country, and make sure we build into those conversations space to acknowledge that. So here's just an example of the team. It includes our learners. So we heard recently the importance of HBCUs and others really prioritizing engaging and preparing the next generation of researchers and public health professionals. And so whether they were PhD students, bachelor students, or others, they have been a part of the process, not just to support us, but to be a part of an actual initiative that is designed to address health disparities, positioning community leaders at the center of it. So the systematic review is still in progress. There are thousands of articles that we are sifting through very rigorously across this team. And we're in the midst of then going through those that have made the cut to determine which ones really do speak to the issues of health disparity populations that are 65 plus with respect to this issue. So we look forward to getting your insights on it. We were very intentional about having a member of our library to help us to think through how we store all of all of this literature once it's curated and once we've approved it, again, with the thought that this will be a central repository that folks across the nation can access as a place that demonstrates our leadership in this space. And certainly I look forward to hearing others that you all may be involved in, so we are not duplicating but complementing. So probably the most important part, and I'll stop, is that we want to certainly complement what exists in the literature with community-based qualitative data, and that's through focus groups to strategically engage health disparity populations in these groups that help us to understand perceptions, attitudes, recommendations, best position of implementation approaches and research studies with them, for them, and co-created by them. And so this is the most important element, and it is not simply to get and understand how they feel, but strategic community leaders like those who are on the call and from these focus groups will be there to help us understand and towards ultimately developing a community majority external advisory committee to make sure that everything related to what we do is community relevant, resonant, and responsive. And so this process in the spring of these focus groups, we'll be looking for those who are particularly interested in informing and guiding and leading our approaches through a community coalition board model, which I'm pleased to share with you, that really has governed a lot of the work of the Morehouse School of Medicine Prevention Research Center and has been scaled to a lot of other networks. So we will continue the conversation, but I'm just very, very excited that a lot of what we are doing is aligned with a lot of the trails that you all have blazed, both historically and currently. So I'll stop there, Dr. Standifer, and certainly can take any questions.
So Mr. Atkins is asking the questions, how can we engage and participate in your community-based programs?
I will put my email in the chat. Certainly, Dr. Atkins, we need you, right? Mm-hmm. So when we think about this phase moving into April, where we want to engage folks, certainly not limited to Georgia. And as someone shared earlier, I think someone shared earlier, make sure I get the names right, because I know we're going to be getting to know each other. Dr. Fong talked about, there are some challenges to community engagement when, thanks to because of COVID, but also the number of people we can reach has kind of been democratized. So I agree with this whole forum. And I know Dr. Standifer, we have been talking about what the second phase of this will look like in terms of this certainly being a private kind of strategic planning session, but something that we have that invites the public. So I will put my email in the chat because we want to be sure that when we develop these invitations for community conversations, that those from around the country that represent our demographic, that they can participate. So I'll put my email in and certainly look forward to engaging with others.